All right, so in this video, we're going to talk about a few different skills, mainly BLS skills, when it comes to manually ventilating a patient. So first of all, we'll talk about oral suctioning. Obviously, you're going to want to make sure that your suction unit works and is on. And then basically, you're going to suction the patient's oral cavity or their mouth until everything that is in there, if there is anything in there, is not in there anymore, because it doesn't make any sense to ventilate the patient with a BVM if there is stuff in the oral cavity or the airway, because you're just going to force that down into their lungs. So oftentimes you can just grab their jaw and then use your suction catheter and suction the oral cavity until you've cleared that of whatever there is in there. Most of the time when you are going to be manually ventilating a patient, you want to use some sort of adjunct airway to help hold their airway open. So that could be either an oropharyngeal airway or nasopharyngeal airway, an OPA or an NPA. You should know that the correct way to size an OPA is from the corner of the mouth to the angle of the jaw. So that looks about right for this patient. And then to insert this, again, you can turn it sideways and place it in the patient's mouth and then turn it like so. So you're basically doing an in and then a turning motion like that. With the NPA, you're going to size that from the nose to the tip of the earlobe, right about the same area as you would with the OPA. If you're just using one NPA, it's good to have the bevel edge face towards the patient's nasal septum, so the middle of their nose. It may also make it easier to insert if you kind of push down on the tip of the patient's nose and kind of scrunch it up like a pig's nose. And that kind of straightens out your path. Also important to know, you're not inserting up, you're inserting straight back. So just like that. Also, there's nothing wrong with inserting two nasopharyngeal airways. So you can do one in each nostril. And then also, in addition, you can have the oropharyngeal airway in. So technically 3 airway adjuncts can be placed all together. Then when it comes to actually ventilating the patient, we're going to use the 2 thumbs down technique. That's really the only technique that you should ever use when manually ventilating a patient. So I'm going to put the mask over their face, and then I'm going to use my 2 thumbs to hold mask seal, and then I'm using my index and my middle fingers on both hands to perform a jaw thrust. What I'm not doing is I'm not pushing the mask down into the patient's face. I'm thrusting their jaw up into the mask. So I'm pulling their jaw up into the mask instead of pushing the mask down into their face. So you're getting kind of 2 benefits in one here. You've got a jaw thrust as well as you're getting mask seal. So then I'm going to have my partner squeeze the bag. The person holding the mask is never going to be squeezing the bag. And we're going to do 1 breath every 6 or so seconds for an adult. And that'll look something like that. Obviously, you're going to have your BVM connected to oxygen at 15 liters per minute. And we're given about a half a bag full, squeezing it nice and slow with 1 hand. The other thing we'll talk about here is the PEEP valve. You should almost always have a PEEP valve on your BVM. That's this piece right here. It won't always come on it, but you should pretty much always use a PEEP valve. That allows you to apply positive index expiratory pressure while you're manually ventilating a patient. So these work, you can set different levels of PEEP by twisting the red knob here all the way from no PEEP at all with it unscrewed all the way to 20 centimeters water of PEEP if it's screwed down all the way. Generally, you're going to start at 5 and then go from there.